Hi, my name's Nancy Poole, and I'm the director of the Center of Excellence for Women's Health and the prevention lead for the CanFASD Research Network in Canada. And this is to introduce you to a series of presentations about research on FASD prevention. So this series shares brief explanations of what we know about FASD prevention from those who are currently conducting research from a number of countries. And the goal is really to make this research accessible and to inspire people to take up the findings in both practice and policy. So you can see we have 5 sections in this series, starting with presentations about stigma as a central issue in preventing FASD, then offering some frameworks for FASD prevention, then looking at what we call level 1 prevention in Canada, which includes broad awareness raising, health literacy, and community-led health promotion efforts. Then looking at what we call level 2 prevention in Canada, which is brief alcohol interventions plus integrated support and referral as needed with all women. And finally, levels 3 and 4 prevention, which is about engaging and assisting pregnant women who use alcohol or are trying not to, and who face related health and social concerns. It also involves supporting new mothers and their children to build on the gains they've made to reduce or stop drinking in pregnancy, to support them to improve their health and their social status, to support attachment and promote assessment of children's health. In this next section, we talk about frameworks for FASD prevention and really have an opportunity to introduce how some countries are framing this work. And the South African framework actually uses the tagline "from hope to action through knowledge," which I think really well captures our aim. So in this section, we hear about Canada's multi-level FASD prevention model, an Indigenous framework from the Future Generations Collaborative, and a comprehensive South African framework for prevention work to be done in educational, health, and community settings. Hi, my name is Nancy Poole, and I am the director of the Center of Excellence for Women's Health and the prevention lead for the CanFASD Research Network. And I'm just going to talk to you a bit about Canada's multi-level model for FASD prevention. So here it is. We received funding from the Public Health Agency of Canada over a decade ago to describe an optimal approach to FASD prevention in Canada. So a group of researchers and practitioners and community advocates came together to collectively articulate this multi-level model. Initially, it didn't include the all-important link to supportive policy. Thus, I prepared an updated description of the model for the CanFASD Research Network, and it's posted as one of their policy and practice briefs. You can see in the right-hand corner. So I'll now walk through each of these levels, noting the research relevant to each section. So there are a lot of activities involved in level 1 prevention, which is about awareness building and health promotion efforts and community development work. And we've really come to see how important it is to link awareness of the disability with awareness of why women might drink in pregnancy, and to build compassion and understanding of the challenges that women face. So here's a few of the many activities involved in level 1: campaigns, representation in the media, warning labels on alcohol products and in alcohol serving establishments, as well as community-wide health promotion strategies. I've featured on this slide an image of Canada's low-risk alcohol drinking guidelines, as it is one place where awareness raising happens, where it's noted that 0 is safest around alcohol in pregnancy. And also a research article that we've recently published that looks at sex, gender, and alcohol use and the implications for low-risk drinking guidelines. Both, the implications related to pregnancy and prevention of FASD, but also how we communicate about the sex factors and gendered influences on women's alcohol use in general, before, during, and after pregnancy. So lots to think about in terms of level 1 work as a part of our framework, and to link it to the other levels. The level 2 part of our model is about discussing alcohol use with girls, women, and their support networks, with all women, girls, and their support networks, really ensuring that health and social care providers are both competent and confident to do this work. The images here are 2 research projects we undertook. The Doorways to Conversation one was based on interviewing and practitioners from across Canada who were working in a wide range of settings about how they are talking about alcohol and other substances and other issues with women in pregnancy and beyond, and really capturing the evidence-based approaches they're already using and the stretch to be even more based in best practice. And next to it is a recent article about preconception work that we were lucky to have published in the International Journal of Birth and Parent Education, really looking at the importance of doing more than screening for alcohol use in brief interventions, but also to really round that out by talking about what women already know, and thinking about all the ways in which change may be important for her, and how to tailor our support so that reducing alcohol in the preconception period is really possible and engaged in. The third level of prevention in our model is about specialized holistic support for pregnant women. And this piece is really, very complex work that, involves attention to all the determinants of health. And you'll hear more about this research study that's featured here about wraparound programs for pregnant and parenting women who have substance concerns in a later part of this seminar series by Dr. Ruttman and Carol Hubberstee. But suffice to say that this this work with women who are really challenged and burdened by a range of health and social problems that makes it difficult to stop or reduce alcohol use in pregnancy, that a particular range of interventions are really important to support them. And all of them need to include practical support, harm reduction oriented support, trauma-informed, integrated with a range of issues about women's health, prenatal health, children's health, parenting, cultural programs, nutritional support, etc. And that it feel welcome, accessible, and not judged for both women and children, so that access to care is really emphasized, and changes are made in a way that supports readiness and the steps to change, not only the focus on alcohol alone. The fourth level is about postpartum support for new parents, and really recognizing that FASD prevention doesn't stop with the delivery of children, but there's so much work we can do to support the changes that women have been able to make during pregnancy, and really, reinforce and support further growth and healing and reduction in alcohol use for new parents. There are lots of examples of this approach as well: home visitation by nurses, mentoring programs such as the parent-child assistance model, whereby women and children are connected to community services and supported over 3 years following the birth of a child that's been substance exposed. And finally, this is an opportunity for connecting women up to addictions treatment, where it's available for mothers and children, so that they may not have felt able to do while they were pregnant, and can find the space and importance of in the postpartum period. And the research identified on this slide is some great research led by a colleague of mine, another research lead from the CanFASD Research Network, Dr. Jackie Pye. And they looked at the work of these PCAP-style programs, the mentoring programs, and really captured the perspectives of the mentors in these programs, talking about what was involved with their work, the contours of the work. And they captured it not only in a research article, but also in a quilt, as you can see here. And the mentors created squares that showed the dimensions of the work. And the advantage to that was a great knowledge translation one, of being able to take the work around the province of Alberta to show others and inspire others to be involved in this level of FASD prevention. Policy does matter so much, both alcohol policy and child welfare policy, and both of them can really support or be major barriers to women getting connected to services and making the kinds of changes that we are aiming for around FASD prevention. And this work that's on the screen here, stealing a bit from Paul Simon's framing about mother and child reunion, taps into some research we did around barriers and supports to women accessing support during their pregnancy, and recognizing just how big a barrier it was if women felt that their children were going to be removed from them if they sought help for alcohol use, and how we need to make child welfare and alcohol policy in a way that emphasizes the importance of wrapping care around the unit of mothers and children, rather than presuming that because women use substances that they can't be good mothers. So that's our multi-level model of FASD prevention in Canada, and some of the research that's been underlying it and evolving from it over time. The key part, I think, is really noticing how many different types of things are part of FASD prevention, and many different activities, many different types of researchers and service providers and community advocates are involved, and how important it is to link and synchronize these efforts so that they reinforce each other, and we don't emphasize one as more important than the others, but really make it a collaborative and mutually reinforcing effort across the country. Just in closing, want to give a nod to Dr. Kurt Fitzpatrick from Australia, who led the Making FASD History project in Western Australia. And I note in his taking up of the Canadian model, he did an excellent job of showing how it's also linked to the work on diagnosis, on intervention and support, as well as alcohol policy and research and evaluation. So it's nice to see the Canadian model picked up and advanced by another country, and hope that that may be inspiring for you as well. Thank you.
The Future Generations Collaborative was founded over 11 years ago as an inside-outside collective impact partnership between Native American and Native serving organizations. Together, we work across systems to address the lasting impacts of racism and colonization on our people, including the reality of historical and intergenerational trauma.
In 2018, the Future Generations Collaborative came together to develop, design, implement, and complete a community-based research project to understand the magnitude and impact of fetal alcohol spectrum disorder in our local Native community. And we wanted to understand what were the system-level issues, the historical issues, the social issues that were driving our rates of FASD in our community, but could also provide information about remedy so that we can design effective strategies, public health strategies to prevent FASD, to advance us further, to advance us closer to thriving future generations.
Well, I'm really grateful for the opportunity to not only reflect on this paper, but more importantly, just what is our landscape these days? How have we evolved? How have we grown in a positive momentum? in terms of understanding fetal alcohol spectrum disorder, that it is a consequence of challenges that have come to us as a result of historic trauma. In the past, many of us have talked about that there was a prophecy among a number of our nations that spoke of there would be a time when there would be those who would come among us who would look different, and in their differences they would change the people. And so it's 40 years that we have been on this journey to understand the impacts of fetal alcohol spectrum disorder on our communities and on society at large. And over that time, I've come to look at that prophecy and understand it from that context of the hope and the teaching that has brought us, that it arrived as a challenge. We have sought to look at the opportunity, and we are recognizing some of the gifts. Because as an Indigenous person, part of what I think is a place of pride for us is to realize that, in fact, Native people do not account for the greatest prevalence of prenatal exposure. And the reason we don't is because in the early days of learning about fetal alcohol, it was our Indigenous communities who embraced that understanding and took it and used it as a strategy to begin to really recognize how to address and why we wanted to address alcoholism in our communities. Because we love our children and we recognize that life is sacred. And as soon as we bring that recognition that life is sacred, then we are called upon to know that we want to invite it, we want to nurture it, we want to celebrate it. And so in that way, I think it's an important thing to look across this landscape of learning and realize that we are still very much in the early days, maybe not infants, not even toddlers, but possibly preschools, still in our acquiring knowledge and learning about not only the impacts across the lifespan and the global impacts that show up in all disciplines and all ways of life, but that we also have the ability to understand that therefore that's an invitation, it's a direction, it's a mandate really to change our systems. And it is one that aligns with our understanding of the equity and lack thereof within our peoples that have created the disparities, the hurt, the traumas, and the self-medication. So I want to hold in it that knowledge and embrace it in a way that then we create an invitation for our systems to understand that, to consider it an Indigenous framework, we need to listen, and we need to hear, and we need to relate, and we need to understand that what we really seek is building trust. And so again, that's another gift that comes with creating knowledge and understanding of the FASD umbrella.
That's where I learned how to treat other people as well, through our trauma-informed trainings and really understanding the brain and alcohol's effects on the brain, understanding historical trauma, intergenerational trauma, as well as healing and all the many forms that can take. So that helped me to recognize the healing in my life and what I had control over, and helped me to understand myself so I can relate to others better and help people in my situation who have the same struggles as me, and help people see their strengths, because what the partners in the FGC have offered me is compassion and understanding and wraparound support for me and my family in our healing. And we've just had so many opportunities to heal and to develop personally and professionally, and not alone, but as a community. I think learning to ask for help was the most important lesson I've learned along the way. And that's something I try to express to others, is ask for help. You're not alone. There are communities to support you.
So at the Future Generations Collaborative, one of the impacts of this paper is that we came together as a community and we built the skills, and we asked for the support that we needed to be able to carry this project out from beginning to end. And that capacity is still in our communities, and it's become the foundation in many ways on which other projects from the Future Generations Collaborative has grown and evolved.
Native American and Alaska Native peoples experienced continued barriers to accessing healthcare from a system that was not designed to care for us. Forced relocation and boarding school era and more have shaped the relationship that Native peoples have with the systems that govern our lives. The legacy of colonization continues to manifest in neuro and environmental trauma by shorter life expectancy for Native peoples who continue to push the colonial structures. Coping with all of this historical and ongoing trauma through substance continues to be a challenge for the community. High rates of fetal alcohol spectrum disorder persist as a major public health concern. And yet we are still here. Our communities are strong, our culture is strong, and our people are strong. And this is why the FGC was founded. The FGC works on an inside-outside approach to both provide systemic technical assistance with current structures and the creation of spaces to remember and reconnect with community, culture, and your own strength.
We are so blessed, we are so privileged to have this whole landscape of natural and traditional tools that can inform our strategies and our practices in a way that in turn grows our self-esteem, our pride, our connection to our land, to our peoples, to ourselves, and to our community in a way that truly we create a collaborative circle of care in which we do indeed invite providers and systems, whether they educational systems, health systems, justice systems, invite them to be a part of our community of healing. And when we do that, and when we experience and are able to positively map the outcomes of those strategies, then we continue in that evolutionary spiral of not only understanding how to address fetal alcohol spectrum disorder, but we understand its gift, its opportunity to radiate that knowledge throughout all of our systems and practices to create true, healthy, thriving communities.
FASD is an important public health issue that exists in our community that has been further perpetuated by systemic inequalities going back hundreds of years. The policy mode works with our community members, leaders, and lawmakers to address inequities such as access to healthcare and mental health services, lack of affordable housing, and racism and discrimination. From developing legislative priorities to collecting testimony from our community, the FGC is committed to carrying the community voice by creating representation opportunities for community and advocating for those most impacted by fetal alcohol spectrum disorder.
One of the things I hope people walk away with when reading this article and learning about this area of study is that there are real lives behind the data. There's generations of trauma behind the data. There's generations of wisdom and love and strength, community strength, also behind the data. It's important that we focus on not just the harms and the opportunities for healing, but that we also focus on the positive contributions of Indigenous people and use those sources of information, the engagement of community, the wisdom of community to inform the public health practices, projects, policies that are really intended to improve the lives of Native people and advance us to thriving future generations.
A lot of the work that I see come out of the FGC that I've had some kind of influence in are based around what I've needed as a community member on the spectrum, and that is mentorship, compassion, all kinds of opportunities to express myself and learn how to handle my emotions, and truly being uplifted by a beautiful community who recognizes my strengths and my leadership, who saw something in me that I couldn't see in myself yet. And really just to see the beauty. And I see that everywhere I go. My strengths are in nature, on the water, parenting, mothering, being an auntie, sewing, music, laughter. I think I'm pretty good at making people feel comfortable. I'm not afraid to be vulnerable. I get nervous, but I still do it anyways because I know that brings comfort to others and helps them come out of their shell. So my life with FASD is still a roller coaster ride. My emotions are up and down like a wave all day long, but I can recognize where that stems from, if it's how my brain works, if it's from trauma, if it's from too much stress in the moment. And I'm learning how to communicate verbally better when I'm upset. I'm still working on that, not holding things inside. But that comes with learning how to trust, and that's what I learned in my experience working with the FGC, is how to trust.
Good day, everyone. The title of my presentation is a guideline for the prevention of fetal alcohol spectrum disorder in South Africa, presented by Babatope for International Seminar Series on FASD, organized by Center of Excellence for Women's Health in Canada. So this to explain the problem in South Africa, this chart shows the prevalence of FASD in 5 countries, South Africa and 4 other countries. You can see the highest recorded prevalence of FASD was in South Africa. So this chart also shows the persistent increase in prevalence of FASD in a province of South Africa from 2000 to 2017. Although this study were not conducted in the same community, but they are conducted in a community with similar characteristics, particularly low-income communities of the province. That's why FASD is a huge public health problem in South Africa. There's no specific policy for the prevention or management of FASD, although there are clauses that could be attributed to prevention and management in other policy documents. To start the conversation for policy development, I decided to conduct this research. The research was conducted in 3 phases. In phase 1, I conducted 4 studies. We have the scoping review, the focus group, the in-depth interview, and a document analysis, a policy document analysis. The findings from the first study was used to develop a prototype document, and the prototype document was used to engage with local and international experts for their opinion and comment, and to redefine the prototype. This was done in phase 2, and in phase 3, a depth field study was conducted with policymaker, teacher, service social service professional, researcher, and health professionals to refine the guideline. The guideline was divided into 4 sections. The first section, we have the guiding principle. You can pause and look at all the guiding principle. I will mention some of them. We have it must be interdepartmental and multisectoral, that it must involve many departments. It must be collaborative. It must be based on evidence, and it must address social determinants, and there must be a clearer pathway for referral. So we also have measures, those the ones that are related to education. You can also pause to read all of them. So I will mention some of them. We have use of peer education in school for FASD awareness, improve teachers training on FASD awareness. We also have promoting healthy lifestyle in school through sport and extracurricular activities. We also have teaching of success and practice in also educational practice. Then we have F-related. So you can also pause and read them. Some of them are improved screening of alcohol use in the clinic. We also have improved training of health professional on FSD. We also have empower health professionals with the skill to counsel and ask questions about alcohol use in a safe and appropriate way. We also have a promotion of the use of contraceptives to avoid unwanted or planned pregnancy, which may lead to FASD. So we also look at the measures that could be carried out in the community. We have the use of community groups. We have the enforcement of liquid laws and regulation of shebins. Shebins are local places where you can access alcohol, where you can buy alcohol in the community. So they need to be regulated. We also have the use of community and religious leaders for prevention. We also have adoption and expansion of non-governmental evidence-based intervention for prevention. In conclusion, FASD in South Africa deserve urgent attention, especially from the government in terms of policy to coordinate relevant prevention and management programs and intervention. I believe developing a comprehensive and multisectoral policy to guide program intervention for the prevention and management of FASD could be a good starting point in South Africa. So these are publications for this presentation. We also want to acknowledge the following organization. Thank you for listening.
So just thinking a bit about these frameworks, the Canadian framework invites us to consider how to synchronize work on awareness raising, brief intervention, and holistic wraparound supports, and how supportive policy underlying the work is really key. The Future Generations Collaborative Framework links historical trauma experienced by Indigenous people with FASD prevention and really well illustrates the connectedness of individual healing, community-level supports, strengths-based leadership, and culture-informed systemic change. And then Dr. Adebiyi describes the work in South Africa to create a guideline for FASD prevention that details guiding principles, education-related prevention measures, health-related prevention measures, and community-related prevention measures. So really important work, I think, to frame the complexity and the scope of FASD prevention that hopefully may really seem to fit one or more of these for your context. And again, if you're interested in discussing the implications for practice and policy, you're really welcome to contact either the researchers who presented in these sections, or those of us at the CanFASD Research Network.